The cost of healthcare continues to rise, both nationally and here locally, and some question whether our healthcare system is sustainable. But who's to blame? Is it the hospitals, the doctors, insurance, or pharmaceutical companies? Or are patient expectations a bit too high? And finally, does Central New York have the same level of care available in other regions? And do we all have equal access to that care? We'll do our best to explore those topics, but first, welcome to this edition of Central here on Fox 68 and My 43. I'm Daniel Pluff, and clearly it won't be easy going through all of this in 30 minutes or less, but we'll do our best and maybe even come up with a few solutions and possibly more questions to some of these issues. I'm fortunate that I do have two local experts joining us for this program to lend their knowledge and probably some advice along the way. I want to first welcome Kimberly Boynton, who is the Chief Executive Officer and President of Crouse Health. 3 years or better in that position, but with the hospital, Kimberly, since 1998?
Correct.
So you come to it with a little bit of experience. Welcome. Certainly be picking your brain tonight about a changing landscape in the hospital environment, et cetera, but welcome to the show.
Thank you. I'm glad to be here.
Our pleasure. Also joining us, Dr. Anthony Tony Scalzo, an oncologist with Hematology Oncology Associates of Central New York, also president of that physician group and practicing medicine now, for 34 years, you told me?
Yes.
Long enough. So you come to it also with some experience, Doctor. Thank you for joining us. Pleasure having both of you.
Thank you.
Let's just start off. I went back and forth. Where do you begin with this? Because there's so many moving parts, obviously. And Kimberly, Dr. Scalzo reprimanded me the other day. Said, "How are you going to do all this in 28 minutes?" I said, "I don't know. We're going to try." But first of all, as you look at just the landscape of hospitals in our area, the veterans community now part of Upstate, St. Joe's being acquired by a bigger conglomerate. It was years ago. Crouse certainly in some financial trouble, now on better ground, a large standalone hospital. But these mergers, acquisitions, we haven't seen closures, but it's happening in some other places. What does all that mean in terms of patient care and services provided to patients, especially here locally?
Well, we're very fortunate in Central New York to have the health care that we do have. The competition is there. There is definitely competition in our marketplace, but it's good for the community. We have a top-notch health care right here in our community. There are very, very few conditions that someone would need to travel outside of the community for.
Which I want to talk about.
And I think we're very proud of that. There are a number of healthcare system mergers, acquisitions taking place across the United States, and that really is the result of all the changes that are taking place in healthcare today.
Healthy probably for the industry, for lack of a better phrase, but is it ultimately going to be good for the patients and those requiring care?
Well, I think it depends on how those mergers and acquisitions are set up. Yep. So healthcare is local, right? You want healthcare to be right where you are, right where your family is. So healthcare is local. So it depends on the structure of the affiliation or merger and what governance is retained in a local community.
So here's just an issue I have, and I've heard it from others, so it's not just my issue. Heavens knows I've got enough of them. But when you go to the emergency room, if you unfortunately have to go to the ER for some reason, you're not met by a doctor or nurse with their hands on their hip waiting for you. It's busy. When you visit somebody in the hospital, you don't see a lot of empty rooms, but I hear there's too many beds, which I guess means we have too many hospitals. Do we have too many hospitals? What's the right number of hospitals for Central New York?
Well, our beds are full. So in the community, the beds are full. There's a difference between licensed beds and beds that are actually staffed and operational. Our staffed and operational beds are full in our community. We need all of the facilities. Now, whether or not do you need 2 hospital systems or 3 hospital systems or 4, you need all of the beds, but then the number of systems is dependent on what the structure might be.
And just to continue on this point for 1 second, another concern that I've heard is, some of these more regional hospitals, smaller size hospitals, the Little Falls, the River, Auburn Hospital, Oneida Healthcare. Do you know Jean Morial?
Yes, very well.
Okay, I know Jean. Oneida Healthcare, now I'm not saying anything, they're in fine shape, serving a population down there, but he said to me, my concern is if we had to merge or be acquired or whatever, we'd have a significant impact on the local economy in Oneida, and secondly, his concern is that some services or some of the things that are provided to patients in that area may be cut back or eliminated. problem?
Well, I think that there's advantages and disadvantages of any merger and acquisition. Again, it goes back to how they set it up. But one of the things that is difficult right now in smaller communities is the recruitment of physicians.
Yeah.
So they're finding it more and more difficult to provide specialty care that they may have provided in the past. So the one physician that did cardiac catheterizations is retiring. They have to replace that. And you can't just replace it with one, you need a backup. So I think that's where it comes into play, is can a larger system help with them with recruitment?
On that note, Dr. Scalzo, there's recruiting in every business, right? As president of your group, your practice, is it difficult maybe attracting oncologists to this area? If I'm an oncologist, I can probably go anywhere in practice. Why Syracuse, New York?
We have had a difficult time in it, and we've had several physicians retire, and so we've been in the business of recruiting physicians for the last year and a half, and it's been very difficult. Part of it is Syracuse.
You don't do it in February. Tell me that.
And many of the people that we have recruited have ties to Central New York. We're looking at a young oncologist now who has family in Albany, and his wife has family in New Jersey, and so they are familiar with the climate, and it's good for them. They're close to the family. They have 2 young children, but it's been very difficult. And many of the young oncologists finishing training programs want to practice in a large city, want to be in a large city, so that makes it difficult. And I wonder if I could just
please,
from a community oncology standpoint, in terms of what my patients see and what I see in terms of what's happened with the mergers, I think my patients get superb care at Krause and at St. Joe's. From a user standpoint, and I think the patients would say that as well. St. Joe's has been taken over by Trinity, and I think if you talk to the patient, they don't.
I'm glad you say that. I bring it up only because so many times, when there's a merger of any type, an acquisition by somebody else, there's usually some changes, and they're not always positive for the end user. But so far, so good, you're saying.
Yes, but the changes that will be difficult are the smaller communities, as Kimberly was saying. Like, for example, in Oneida City Hospital, if they can't recruit an oncologist to do cardiac caths, there's a push to quality, which means doing the same procedure frequently. So in Oneida City Hospital, and I'm just using that as an example, if they do X number of caths per year, and Krause does 6X caths per year, that's
there's always going to be the need, I guess, to go elsewhere for something if the hospital does. But as we sit here in the studio, we could walk up to Krause. It'd be a long walk, but we could do it. If you're in Oneida, if you're in Auburn, and those hospitals are gone, you've got a problem. They're serving.
Yes.
So but just one other point on this, though. This is another thing that Jean Morial was trying to educate me on. One of the things, I guess, academics and others are looking at is one way to control the costs, the escalating costs of this field or this industry, is to somehow limit or control access. Now, if I needed an MRI, I could probably, right, doctor, get an MRI within 24, 48 hours.
Correct.
In Canada, it might be 24 weeks. It might be 48 weeks. Do we need to look at that, which would probably take some services away maybe, but do we need to look at that as a way of containing costs? Control the access more?
I feel that as a physician, we need to be stewards of the health economy. But on the other hand, we serve our patients. And I also think that patients in the United States have a certain level of expectation. And I think changing that level of expectation, the services that are available, there's all sorts of issues surrounding end-of-life care. I think that those are issues that the public should decide, and these are issues that the politicians, particularly in an election year, are afraid to face. I think that
this whole issue is right up there with Social Security. Nobody wants to touch it, it seems.
Well, and I think Kimberly needs to keep Krause solvent. I want to keep my community oncology practice solvent, and we serve the patients in the community. And I think that that's a larger issue, and it's difficult for, we have some input with our congressmen, et cetera, but don't you think, Kimberly?
Oh, absolutely.
Speaking of solvency and money, that I'm always drawn to that part of it. So as I'm learning and going through this, Kimberly, it seems to me hospitals are paid, and I put it in quotations in my notes here, but hospitals are paid on performance, which on the surface doesn't sound like such a bad thing until I started to look at this. Now, if a hospital has a high rate of infections or deaths from, Okay, that's a problem. But if Dr. Scalzo, if I'm a patient of Dr. Scalzo and he removes and I'll pick on myself and no one, he removes a malignant tumor from me in your hospital, but something goes wrong and I have to be readmitted, I mean, that's a problem for your hospital. Someone's looking at you saying, well, you've got a readmission situation here, and that's kind of a ding, isn't it?
Right, exactly.
Why?
Well, because the goal is to get someone healthy and that they're not readmitted within 30 days. That you
Doesn't
take
always
care of their
happen, though,
care.
right?
No, it doesn't always happen. There are some things that are beyond your control. You know, we have patients that come in and we care for them, and the physicians do the best that they can to get them back to health. And they set them up with outpatient care. They set them up with certain pharmaceutical. They want them to take medications going forward. The patient also has to be compliant. And when you come into a situation where the compliancy isn't there, readmission will occur. The goal is to reduce those readmissions and make sure that the care is administered in the appropriate setting.
Yeah.
So outpatient setting.
Dr. Scalzo, let's pretend that Kimberly's not here just for a moment. Does this put you at any odds or conflict with any hospitals? For example, if I'm that patient and you either think I need to stay in the hospital longer, the hospital wants me out in the nicest of ways, right, as soon as possible. They've got to ration resources, I get it.
Well,
but go ahead.
A patient should not be in the hospital if they don't need to be in the hospital. It's actually a higher rate of infection that can occur. The best thing for the patient is to be in the appropriate setting, and if that's home, if that's in a rehabilitation, they should just be in the hospital for the period of time which is necessary.
Agreed.
And it's not just a resource issue.
Isn't it hard to determine sometimes, though, how long that is or no?
Well, it's the physician's call.
Okay.
Absolutely.
Okay.
Absolutely.
Okay. So back then, do you feel any conflict? I mean, is there a time when you either you want to readmit a patient or keep a patient longer and you're feeling some pressure that maybe you shouldn't?
No, not at all. Not with neither with St. Joe's nor with Crouse Hospital. I don't think we have just the opposite of an adversarial relationship. I think we work together. And really, the issue that you're speaking to is that when a patient has reached what we say maximal hospital benefit, in other words, what needs to be done in a hospital setting has been completed, the patient is well enough not to require that type of acute care, then they can be discharged. The issue arises that with the social structure changing, that and the population aging, there are not enough rehab facilities,
right,
extended care facilities. Family is not what it used to be 50 years ago.
Absolutely, right.
You kept grandma at home.
Right.
That has changed dramatically at the time when the population is aging. And so what happens is it's not an adversarial relationship at all in terms of keeping the patient in when they need it, but when they need to be discharged, it's difficult sometimes to find them a safe discharge. And as Kimberly alluded to, you don't want to keep them in the hospital because in a way that's a dangerous place with infection, et cetera.
Absolutely.
So you want to get them out at the right time.
Yeah, and back Kimberly, just again, keeping things solvent and where we're making our money and all of that, there's been a fairly recent phenomenon in that there's you mentioned competition earlier. There's quite a bit of competition that goes on between the hospitals. I mean, jokes have been told, you go down 690, the billboard, you can have kidney out, your tonsils out, whatever.
Right.
but I mean, realistically, and I don't mean to be funny about it, but if I'm in the back of Manlius ambulance being driven in, bleeding out, I'm not thinking who's the best hospital for. Why all that competition? Don't we just go where our doctors tell us or where the ambulance takes us?
Well, no, it's the patient's choice. You always have a choice as to which facility that they take you. EMTs, when you're in the ambulance, will say, well, if this is your condition, we suggest you go here.
Right.
Or they may talk about the wait time that's occurring.
Because certain hospitals might have some advantages for, heart.
Well, take trauma, for
Trauma.
example. If you were the victim of a gunshot, you're going to go to Upstate. I mean, they're the trauma center. That's where they will take you. But so there's certain specialties where we each have our own expertise in. But there is, I mean, of course, I want you to say, take me to Crouse no matter what, but
we'll run that tag on the bottom of it all show long. Is it true in the physician practices as well, Dr. Scott? I think about oncology, and I said earlier, if a tumor had to be removed, I mean, is that price pretty much set? It's not like you're shopping that product, correct?
Correct.
Or, I mean, should you? I don't know.
You're not shopping a price, you're shopping an expertise.
And okay, so then the follow-up obviously is, is there a price variation for certain expertise, in your view?
I don't think in the community there's a tremendous, because really that is set by the insurance company or Medicare. So that I think if you go to an institution, for example, like Sloan Kettering or Dana-Farber, and they're out of network, and it depends on your insurance plan.
Sure.
Then it may cost you more. But if you have someone who's participating with an insurance company or with Medicare, then that price is set.
Okay, last question on this, because you guys are making me run a little long. So what I've also noticed is, I observe what's going on in our community is, years ago, if you needed some type of surgery, whatever you want to call it, you went to the hospital. I'm lucky, if health-wise, but I've had a couple of times when they've had to come into me, and it's not in the hospital. It's in these surgery centers. That hurts your business.
It has. It has changed our business. So when surgery centers first came to being, Crouse Hospital actually had the first one in the Northeast. We put it right across the street from the hospital in the physician's office building. We later built another one down the street at Madison Irving Surgery Center. And we've seen a decline in the number of surgeries taking place because there are independent surgery centers being built and there are more office-based procedures. So because of the advances in technology, the advances in medical devices that are utilized, implants that are utilized, surgeries have changed. At times have changed, surgeries have changed. There's more that it is safe to do in an outpatient setting, and then there's more to do that's safe to do in a physician's office. So the surgeries that we have left in the outpatient area are more complex and longer. So our volumes have gone down, but we still are very busy.
Let me talk to you both a little bit about this notion of access to care as well. On other shows we've done, Syracuse Police Chief Frank Fowler sat where you're sitting, Syracuse Onondaga County District Attorney sat there as well. I asked, when we enter the criminal justice system or law enforcement, are we all treated the same? And I thought that's a good question here. For however we enter the healthcare system,
Yes.
do we all have the same access? Do we all get the same level of care, in your view?
Hospitals in New York State are not for profit. There are no for-profit hospitals, so our doors are open. We have to take anyone who walks in the door and we treat them all the same. Absolutely. They have the same access to the care.
And forgive the question, but so if someone was of significant wealth, at least locally, they're not going to be able to receive any different care than someone who's coming in without coverage, perhaps, or what have you.
The clinical care that they receive is the same.
Okay.
Yes.
There was a story that I want to credit James Mulder from the Syracuse Post-Standard, Syracuse.com, wrote a story a while ago that said, oftentimes there's quite a relationship between poverty in Syracuse, which is a major problem now, we've talked about it, and healthcare. And that, quite frankly, depending on where you are, particularly in the city's south side, as an example, you may end up requiring a hospital bed at a much greater rate than others in the area. And if you'll forgive me just to read something to you and have you comment on it, but according to the study that was done, if you're on or live in the city's south side of Syracuse, you're about 2.5 times more likely to require a hospital bed than, say, residents who might live in Skaneateles or Manlius that had the lowest. Poverty and healthcare, hand in hand.
Well, when you break it down and you look at poverty, what are you looking at? Well, you're looking at a well-being. Do they have these individuals had the same access to the nutritional foods that you or I have? Have they had the same access to health and wellness? Are they exercising at the same rate?
Right.
They are chronic conditions that exist, and if they don't have that access to their care on a regular basis from a physician or being able to be treated on a regular basis, have the transportation to get to that treatment, they may not be following up on their chronic condition. We are very fortunate in this community, though, to have Syracuse Community Health Center. And Syracuse Community Health Center does a phenomenal job of taking care of patients within our community who have a lack of means or socioeconomic.
I'm really late, but I wanted to ask you this, Dr. Scalzo. And you alluded to it a moment ago. I was talking to Kimberly about advertising for hospital care and all that. You can't turn the television on without an ad for, if you've got cancer, you need to come here. If you're diagnosed with this, boy, this is what we do. Which kind of leads to my question I opened with, is the level, the quality of care, particularly as it relates to oncology, the same here as what I could get somewhere else?
Yes, absolutely. There are some things, and Kimberly alluded to this, there are some things that we don't do in the community. For example, allogeneic bone marrow transplants when you're using someone else's bone marrow and giving it to the patient.
Would you farm that out? If I needed that, you would say, look, you need to go here?
Correct, correct. So that's not done in the community. But there's several aspects of that, of the quality of care. And I don't mean to be an advertisement, but our group participates in over 50 different clinical trials that we have brought into the community because of our affiliations with Sloan Kettering and Dana-Farber, Roswell, University of Rochester, as well as the NCI. So these are available in the community that might not otherwise be available. In terms of the experimental drugs that we can deliver and the standard drugs that we can deliver, which is the same here as it is any place in the United States. The other issue
is...
But
you've seen the ads. I mean, they're compelling.
They're compelling.
You think twice about it.
Yeah, absolutely. But I really don't believe the quality is any different. Plus, we frequently send patients out for second opinions because, there's no cookie cutter. Not every case is exactly the same.
Right.
When there are questions about care that have not been researched, we send them out for second opinions. And then the other issue is that because of our involvement with our national societies and the National Cancer Institute and going to meetings, et cetera, we have personal relationships with world-renowned physicians all over the country. So if you had a client who had a sticky financial question, could you get on the phone and call the Nobel Prize winner in economics?
Probably not.
I can do that in oncology.
Yeah.
I can do that. I can call the top breast cancer researcher in the field, et cetera, and they're accessible to me usually, if not that day, within 24 hours.
It's actually good to know, reassuring to know, and I appreciate that. Let me switch gears here again. The clock is never my friend on this show. Let's talk about the drug companies just for a moment. Kimberly, just a while ago, there was this big uproar concerning Mylan Labs, I believe. The EpiPen goes from $100 per hit to $600, now over time, but nonetheless. And the argument was, there's no new technology here. People were talking about the affordability. I don't know the interaction between hospital and pharmaceuticals. Can you talk to that issue at all? Is this part of the problem with costs going up?
Absolutely, it is part of the problem. And what we're seeing right now are smaller pharmaceutical companies who have brought a product to market being purchased by larger pharmaceutical companies, and then them raising the price after that consolidation. And there's the issue is federal regulation. So this is an area, and I don't say this often because believe me, there's plenty of regulation in healthcare where we could use some intervention into the federal government taking a look at this. We collaborate on this.
But the CEO of Mylan would say, we charge X for the EpiPen, and then whoever sells it to the user, they upcharge it, and almost saying, if you're getting drugs at the hospital's upcharging, et cetera.
Not to the extent that they're raising the prices.
True in cancer. I'm not telling you your business, but chemotherapy, it's a drug therapy. Those drugs getting more and more expensive?
They're getting more and more expensive, and the newer drugs are getting very expensive. And the margin that we make is controlled by the insurance company and Medicare.
But Dr. Scalzo, it's so limited time. But I got to take the other side of that and say, if I'm the drug manufacturer, clearly no, it doesn't cost $25, $50 for the pill. But they put millions, if not billions of dollars into the research, the development, pushing it through the FDA process. That's what you're paying for, correct?
Correct.
I mean, do you give them any sympathy there?
I do. And I really, you said at the beginning, maybe we'll have some solutions. That's a solution I don't have. I don't know how to reconcile, squelching, paying high prices and controlling price and not squelching innovation and research.
Right.
I don't know how to reconcile that.
Well, and I think there's two different things at play. There's new drugs brought to market that, because of the research and development costs that went into that, it's at a higher price. Understandable, that has always been the way it is. But what we're seeing now are drugs that were already in the market,
right,
and then them raising the cost because an acquisition or a purchase took place. And that's very unfortunate.
Right. Now, you realize I have to skip my whole section on insurance companies because we don't have enough time, but maybe we'll have the two of you back. You're on retainer, by the way, for coming back. let's just wind up with a couple of end notes. Number one, Kimberly, we complain about healthcare. You know, we complain, oh, the waits and. But what's working, particularly in our area? I mean, when you look out and see what's happening here locally, what strikes you as working, effective? It's going the right way.
What I would say is that although there is the billboard wars,
Yes.
we call them, where we're all advertising and we're highly competitive, the institutions work very closely together. So when it comes to care, there are transfers of patients between institutions based on what they need. If a baby is born at Upstate Community and needs the services of the neonatal intensive care unit at Crouse Hospital, that baby would be transferred in.
You know, that happened to us.
Yeah.
Yeah, we took an ambulance ride over.
Right.
She was this big, but so there's collaboration.
Collaboration.
But again, patient care. Patients are receiving proper care. Always room for improvement, but
Oh, of course. I mean, we always want to improve upon the quality. We want to keep high quality, low cost care right here in our community. And we want that access to care that people need. There's certainly areas that we could recruit additional individuals.
I guess I would have been surprised if you answered the question differently, but I was happy to hear you say that, again, and we didn't speak to orthopedics, we didn't speak to cardiology, which I think we're known for in this area.
Absolutely, yes.
But as it relates to oncology and most other, but you're saying it's pretty good quality care right here.
I think it's superb, and the other advantage, the wonderful advantage as a physician working in this community is because of the medical center, and because many of us have been trained here. And in oncology, we use a lot of other subspecialists for complications that may occur. That I can get on the phone and call my acquaintances and frequently my good friends and have a patient seen sometimes within several hours of the phone call. And you know, you can't do that in a big city.
No. So
and I think the care here, because of that, is in some ways superior.
So what is the biggest problem? What's your biggest worry, Dr. Scalzo, going forward as it relates to the whole healthcare field, not just the oncology?
That the system can't support the economics of what's happening. We're getting into this.
Costs are going up.
Costs are personalized medicine, and we're developing these drugs that affect certain mutations in the cell. This R&D is very expensive.
Kaiser's Family Foundation said, out-of-pocket costs are going up at a faster rate than the premiums, and the premiums are going up fast, correct?
Correct.
Same question, do you agree? I mean, what's the biggest problem going forward from your standpoint running a hospital?
Controlling the costs. Absolutely. There's so much that's beyond your control when you speak of the pharmaceutical. We need to make sure that we have, and that's our responsibility. Crouse Hospital is a community asset. It's our responsibility to maintain that asset.
But again,
make sure
we keep going back to the pharmaceuticals. It's a little pet peeve because we're all on some pill for some reason or another.
Okay, so don't just say pharmaceuticals. Say medical devices, new technology, IT systems. I mean,
But this
all of
stuff
the
is
things
so
that
expensive to
very
develop.
expensive. It advances the care, but it is very expensive. I'm not saying it's unjustified. In certain cases, it is unjustified. But that cost, that increase in cost, we have to be able to keep up with it. It's like technology. I mean,
you people, you two have got me out of breath. I'm going to need some medication. Hold on 1 minute. I just want to remind all of you that we do read and enjoy hearing from you, your feedback. I want you to visit us at foxsyracuse.com. Send us any emails, questions, thoughts, ideas for future shows, your thoughts on healthcare, whether or not we should do a follow-up here as well. All of your emails, good or bad, we read them and we appreciate your feedback, so please visit us online. There's time enough to say thanks to both of you. Kimberly Boynton, as Chief Executive Officer and President of Crouse Health, thank you so much for joining us. Again, it's a lot to compress here. I've left out the whole insurance issue, but maybe you'll come back. Thank you.
absolutely. I enjoyed our conversation.
Dr. Tony Scalzo, an oncologist with Hematology Oncology Associates, or did I reverse that?
Oh, that's correct.
Hematology Oncology Associates of Central New York, thank you for your insights as well. Some good points raised, and I think we ended up more on a positive note than negative, so I'm happy about that. But thank you both. Appreciate it.
Thank you.
That's our program here from all of us at Central. I'm Daniel Pluff. Thank you for watching. We'll see you another time.